Fragments. This is about this is 26-year-old lady. She is from West Bengal. She presented to emergency department with the complaints of fever for 2 months, with a rash, hyperpigmented rash all over the face and the body for past 20 days, with breathlessness in past 1 week. She presented with the complaints of fever, which was high grade, no chills or rigors, lasted all the day, associated with generalized body tiredness. Rash was multiple hyperpigmented to dull erythematous looking plaques noted on the scalp, forehead, eyebrows, malar region, but it's sparing the nasolabial folds. She also had a history of photosensitivity and alopecia in the past, no history of joint pains or joint tenderness, no history of hematuria, decreased urine output, no dysphagia, no bluish discoloration of fingers on exposure to cold, no history of weakness of limbs or burning sensation over the limbs. Past medical history, no other comorbidities, had a multiple previous hospitalization with the above complaints, multiple transfusion history with red cells and platelets in last 2 months, no history of miscarriage or abnormal uterine bleeding, personal medical history, weight loss of 8 to 10 kgs in last 2 months, loss of appetite, normal bladder and bowel habits, normal sleep pattern. So on examination, she was conscious, obeying commands, vitals with a pulse rate of 88, with a BP of 130 over 78, the temperature of 101 and the 102, 101. And she, on general examination, she had a multiple hyperpigmented rash with an nasolabial sparring. Pallor was there, icterus was there, multiple cervical lymph nodes, left supraclavicular axillary lymph nodes, and clubbing, cyanosis, pitting, pedal edema. CVS S1, S2 was there, no murmurs, respiratory examination, bilateral vesicular breadstones, and abdomen was soft, non-tender, no organomegaly. CNS examination was GCS was 15/15, no neck stiffness or cerebellar signs. So, differential diagnosis with the history of fever, thrombocyte fever with features of hemolysis, jaundice, and icterus and pallor with the history of weight loss. Initial differential we kept is systemic lupus erythematosus, any hematological malignancy involve multiple lymph node involvement, pregnancy-related HELLP syndrome, which was ruled out later, thrombotic microangiopathy and conditions, and event syndrome. Investigations was done, which shows the HP of 6.1, which was a microcytic hypochromic anemia with the retics of 3.08, which was corrected. And it shows peripheral smear shows anisocytosis, poikilocytosis with the fragmented RBCs and the schistocytes of 1%, which was the initial presentation. Platelet were 23,000 with ANA positive of 2 plus speckled with the LDHs of elevated, which shows the hemolysis. BVOS was negative, and LFT also shows mild hyperbilirubinemia with the SGOT-PT was mild elevation. RFT was normal, PTINR was normal, electrolytes was normal, DS-DNA was mildly elevated, C3 was low, C4 was normal, bone marrow was done in view of anemia and thrombocytopenia, which was normal cellular marrow with normal hematopoiesis. 24-hour urine protein was done. After the urine protein shows proteinuria, which shows 563, and DCT was done, which was 2 plus. Anyways, she was having multiple episodes of transfusion outside. They did not consider as a significant. So the diagnosis of SLE was made after the initial examination and the evaluation. ULAR ACR criteria shows 36. So she was planned for renal biopsy. She was doing well in the ward and are waiting for the biopsy to be done. And we are planning for the lymph node biopsy also. In Warfare lymphoma is one of our differential. So she was planned for a methylprednisolone if she worsened, but the renal parameters was initially normal. So we hold on with methylprednisolone, planned for a prednisolone. She was started with piperacillin tazobactam in of a fever, and ICQ also was started in the ward. So during ward stay, day 10 in hospital stay, she developed a sudden onset seizure, which was GTCS, followed by a drop in GCS. So immediately MRI brain was taken, and she was initially on examination, she was not moving her left upper and lower limb. MRI brain was taken, which shows the features of right MCA, in fact, involving corona radiata and the capsuloganglionic region. So she recurrently had a seizure post that, which was managed with levetiracetam. And after that, we repeated the parameters, which shows the HP of 5.8 and schistocytes were 7, which shows the LDH of 4,000, which means the hemolysis was worsened, and the platelet of less than 10,000. Initially, we thought due to the platelet that she may have an intracranial bleed also. And then after that, MRI shows the infarct. Adams 13 was sent in view of a TTP, which also shows low. So 5.8, diagnosed as a TTP with a plasmic score of 7, which shows 72% of risk in severe Adams 13 deficiency. So TTP and SLE So our patient presented with a SLE and developed a TTP in between in the ward stay. So what about TTP in SLE or TTP as a presentation in a SLE? So it's a very rare case. It's less than low as a 0.5% as the incident was reported as of now. So the mechanism of a TTP is the inhibition of action of metaproteinase by the autoantibodies to atomstatin. So there are two types of TTP. One is the inherited and one is the acute one. Acute one is the autoantibodies against the atomstatin, or the inherited is the deficiency of the atomstatin, which causes the bigger molecule of 1 milligram and causing microangiopathies. So TTP in SLE, we have a idiopathic TTP and the TTP in SLE. The differential in most of TTP in SLE will come with the predominance, female predominance, and response to plasma exchange is bit poor compared with the idiopathic TTP. And need for immunosuppressives is in most cases we need to give aggressive immunosuppressive therapy, and the relapse rate is also very high in a patient with a SLE and a TTP. And the mortality is also a bit high compared with the idiopathic TTP. Atomstatin activity will be variable. And SLE TTP with the idiopathic TTP, the studies, there is one study which was published in a Rheumatology Society, which shows us more of the SLE related TTP patient. They have a younger age. The mean is 41 years, and the low platelet count at the time of diagnosis, which was compared with the idiopathic TTP. More chance of renal involvement and needing more plasma exchange session comparatively with the idiopathic TTP. And chance of recurrence also was very high in a case of SLE related TTP. So diagnosing difficulties whenever the patient presenting with the SLE and the TTP, it's bit of difficult to diagnose. Both the condition will present with the same like hemolytic anemia, thrombocytopenia, abdominal pain, hemolysis, and sometimes CNS lupus also present like a TTP with brain involvement. The blood smear and the detection of schistocytes is essential to categorize microangiopathic hemolytic anemia related TTPs. An initial schistocytes count of more than 1% in the absence of any other cause of thrombocytopenia is strongly suggestive of TTP with other features of TMA, microangiopathic hemolytic anemia. And response to treatment is SLE secondary cases having a lower response. The response time will take longer in a SLE related TTP compared with the idiopathic TTP. So treatment options, what we have for a TTP with SLE patients are cyclophosphamide, rituximab, MMF, hydroglucocorticoids, plasma exchange therapy. Plasma exchange therapy is the standard one, what we are following here. And cyclophosphamide involve a young woman and the fertility we are avoiding mostly in the young woman patients. And rituximab is a cost burden is there. And MMF and the high dose glucocorticoids are not very superior compared with the plasma exchange. Even though plasma exchange is very costly, it shows us the good outcome in a patient with TTP with SLE. So plasma exchange remains the principal treatment for patient with TTP in SLE. Other contraindication should be considered as a hemodynamically instability. That and that we have to consider. Some patient will not tolerate the plasma exchange if they have a bad hemodynamically instability. So belimumab is a new drug which was a B lymphocyte stimulator specific inhibitor, which can be used as a second line, but even though plasma exchange is predominantly considered as a principal management. So this is one of the study which was released and published in 2019, which shows how the plasma exchange help in TMA, TTP and all, which shows us the evidence of whenever the plasma score is less than 5 and the early initiation of plasma exchange less than 24 hours will show the good benefit in a patient with TTP. So when to stop the plasma exchange? So there is no clinical parameters predict the required duration of plasma exchange in a patient with TTP. So British Hematological Society give the guidelines. So minimum of we should continue the plasma exchange after attaining these conditions, minimum at least 2 days after attaining these conditions, with the platelet counts returned to normal or more than 150,000, normal neurological status, rising hemoglobin and normal LDH. We discussed with our hematology, they are considering the same cutoff of 1.5 lakhs. But in view of a financial constraint, we are not going towards like a 10 or 12 or 13 sessions of plasma pheresis. So in our patient was immediately shifted to ICU after the diagnosis of TTP, after discussed with nephro and hemat. So plasmapheresis was started. Her GCS was improved after the 3 cycles of plasmapheresis. So physiotherapy for the left hemiparesis was conducted, and currently she was started with, she received methylprednisolone. She is currently on prednisolone 1 mg per kg dose. Platelet from 10,000, the latest platelets was 72,000 yesterday, which was yesterday, and cystocytes also came down to 3%. Overall, she shows the improvement. So the landing point in this is TTP and SLE will can come together concurrently or sequentially. The difficulty of diagnosing between TTP and SLE. So we can use the Adams 13 cystocytes and consider the TTP as a cause whenever the patient is presenting with a neurological manifestation. So early use of plasmapheresis in the TTP show the good outcome, even though our rheumatology also having the documentations that the early plasmapheresis in the TTP patients shows a good outcome.
Thank you, Brightus. Does anyone have any questions or comments? Maybe perhaps in this patient, because there was an alternate cause of thrombocytopenia and even hemolysis, it's definitely difficult to know when to stop plasma exchange. Probably at least the hemoglobin needs to be stable at minimum. Even the stroke, I mean, each of the manifestations could have been caused by, SLE causing a vasculitis, CNS vasculitis. But because the schistocytes were so high, I mean, I don't disagree with your diagnosis. Sure, thank you. One more thing is that the patient probably didn't need pip after the cultures were negative.